Good morning to all of you. On behalf of the Society for Health Research and Innovation, I warmly welcome all of you for today's CPD program on common pediatric eye problems by Dr. Hiranya Abeysekara, consultant pediatric ophthalmologist, Lady Ridgeway Hospital for Children. Please be kind enough to mute your microphones and switch off your camera throughout the session to avoid interruptions. If you have any questions, you can ask by using the chat box and they will be answered at the end of the session. Webinar link will be available until 9:45 a.m. to you. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And the CPD points are strictly adhered to the NCCPD guidelines. Now, I warmly welcome Dr. Hiranya Abeysekara to start the session. Over to you.
So, this topic about common pediatric eye problems will be practically important for a lot of doctors. Maybe you are working in a OPD, maybe you have just qualified and you want to start a private practice. So, kids might come with eye problems, and you may be the first contact. So, you should know particularly when to refer and when to treat. So this is a guide for main pediatric eye problems you would encounter in your practice. So actually talking about our speciality, it's pediatric ophthalmology is a new speciality in Sri Lanka, relatively new. The eye unit at Lady Ridgeway Hospital is about only 10 years old. So we'll talk about the requirement of a pediatric ophthalmologist in the community. Eye problems in children are different from those of adults. That is the main reason. And the other thing is so many eye problems in children, they are linked to the development of vision and the general development of the child. And sorting out these problems need to liaise usually with pediatricians and often need multidisciplinary approach. So it has to be done in a children's hospital. So you need doctors who can examine kids with special needs confidently and find out their problems. So what are the common causes of childhood blindness in the world? Vitamin A deficiency leads. Of course in Sri Lanka it's not common, but worldwide it's the commonest cause. Childhood cataracts are common. Retinopathy of prematurity is not a problem again in Sri Lanka, but worldwide there are so many kids going blind due to retinopathy. Refractive errors is perhaps the commonest cause in Sri Lanka, what we see in our community, but worldwide also it's important. Inherited retinal diseases is also an important topic. So how you identify whether the child is having a eye problem or not? Child may not directly complain. The parents might not directly complain. So apart from the direct complaints, other than like red eye or eye pain, you can judge whether there is any eye problem. Particular clues towards eye problems are particularly family history. You can ask from the patient. And if the patient has particular medical problems like nephrotic syndrome, which warrants the patient to use steroids for a long time, can lead into eye problems. Then certain causes of developmental delay can be linked to eye problems. So you need a pen torch to assess basically, but with pen torch you can't do everything. And you need the skills of, you need to develop a bit of skills with direct ophthalmoscope to diagnose or to screen eye problems in children. It's handy if you can have a Snellen chart, but it's not always possible in a practice. So what are the components of vision? Visual acuity, that's what we commonly call vision. Color vision is an important component of vision. The three-dimensional vision or stereopsis, or else in a more specific mean, depth perception is also very important part of vision. Visual field is important, and of course contrast sensitivity. So this is a graph which shows development of vision during childhood, so which shows the most development occurs during the first few months, during the first year. So by the age of 6 years, the adult level of vision, the 6/6 vision or 20/20 vision is reached. The common eye problems, particularly what we see in our clinics or what you might see in your community, are reduced vision due to refractive errors, then squints. The parents might often complain of squints. Red eye may be a common complaint, particularly when the children develop seasonal type of allergic conjunctivitis. So you might encounter watering or excessive tearing, particularly in infants. Trauma and foreign bodies, ocular foreign bodies are also not uncommon. So there are uncommon but very serious problems, problems which can affect the vision, perhaps the life of the child, like childhood cataracts, retinoblastoma is eye cancer which can affect the life expectancy of a child. Childhood glaucoma can affect the vision seriously. Other congenital malformations are important. Actually, retinopathy of prematurity is rare, but it's common in our clinics because we see all the retinopathy of prematurity cases. So let's talk about squints first. Why we should know about squints is that it can be linked to neurological abnormality or important ophthalmic pathology. Definitely, if there is a squint, if there is a misalignment of the eyes, the vision development is hampered. So it can affect the development of vision of the child, and the child can develop amblyopia later on in the childhood. So we'll talk about amblyopia later on in the talk. Stereopsis or three-dimensional vision can get affected if the eyes are not aligned properly during the infancy. And finally, there can be cosmetic issues to the child when the child starts going to school. So if the parents come with a child and say, "Doctor, my child has a squint," there are several things you have to do. Please go through the history, maybe family photos, do a general examination to see whether the child is having any syndromes. Hirschberg test is a very simple, important test we can do in our clinic. I will describe how to do it. Cover test is also important. Eye movements you can do. These are very simple things. Only the red reflex needs a bit of skill and a direct ophthalmoscope. Also, fundoscopy needs a bit of skill and a fundoscopy, which you can easily develop in your practice. So when there is a complaint of a squint of a child, please never ignore the complaint and say things like it will go away after 2 years, because that is not a scientific statement. So Hirschberg test, very simple. You just need a pen torch. Please hold it 50 to 75 centimeters away from the child. You can ask the kid to look at the torch or look far away from look at a far away target and observe the light reflex coming from the cornea. So it should be central like this. The abnormal Hirschberg tests are like this. This is a convergent squint. The light reflex falls in a different part other than the center of the cornea. So this child is having an exotropia or a divergent squint where the light reflex falls away from the center of the cornea, medial to the center of the cornea. So eye movements we all know. We all learned this during our undergraduate days, checking the eye movements for each muscle. Cover test may be a new test for you as general doctors. So what you do is you hold the pen torch or your or any target for the patient and observe for any deviation of the eye. If you see one eye straight and one eye is deviating, you hold a cover, maybe a piece of paper, maybe your own hand, or maybe you can use parent's hand instead to cover the eye which is fixing the eye which is straight, and you will see the movement of the other eye. So that is called the cover test. So that confirms that there is a squint. So if you are in doubt, you can do the cover test, which is a very simple test you can do in your clinic. And to do red reflex, you need to master the ophthalmoscope. So red reflex checks the clarity of the optical structures of the eye. So you have to set the ophthalmoscope to check the red reflex. First, make sure the latch is open for the transmission of light, and the bigger aperture is selected, and make sure it's not put into high plus or high minus, and make sure it's set for 0 by rotating the dial on each side of the ophthalmoscope. So red reflex just as goes, what happens is the light coming from the ophthalmoscope goes through the patient's ocular media, the cornea, anterior chamber, lens, vitreous, finally hits the retina, and it reflects back through the same media and goes through the ophthalmoscope, same aperture, and focus on the examiner's eye. So you see the red glow coming from the ophthalmoscope. So it's not fundoscopy. So it's done about 50 centimeters away from the patient, and better to aim both eyes simultaneously. It's better to do this test in a darkened room, so you will see the dilatation of the pupil due to darkening. And get the attention, but do not encourage the child to look at the light of the ophthalmoscope, otherwise the pupillary the light reflex will come up and the pupils will constrict and you will not see the red reflex properly. And if it is very desperately small pupils, you can dilate with tropicamide 1%, which is a harmless drug to use in any clinic. So how to check red reflex, we'll try to demonstrate with the video. So it's better to ask the child to look something behind you, not the ophthalmoscope light. So and then you will see the red reflex. So normal red reflex is the top picture, which is the red glow through the pupil, and in the second picture, the right eye the normal red reflex, the left eye is the absent red reflex. Third picture shows the yellow reflex or xanthochorea. Fourth picture is diminished red reflex due to refractive errors, and the last picture shows leukochorea or the white reflex, usually due to cataracts. So you can actually detect, you can suspect, it's not a diagnostic test. To diagnose conditions, you need to do further testing. So you can suspect congenital cataracts, congenital glaucoma, retinoblastoma, and abnormal refractive errors, and some certain retinal abnormalities. So this is a very effective way of early detection of vision and potentially life-threatening abnormalities. So the next topic is fundus examination. So there are so many gadgets we can use to examine the fundus. Of course, in your clinic, what you use is the ophthalmoscope. We call it direct ophthalmoscope because we have an indirect ophthalmoscope as well, which is a head-mounted gadget. We can get a three-dimensional picture of the retina with the indirect ophthalmoscope. And of course, we have the slit lamp biomicroscope. Again, gives a very nice view of the retina and ocular structures, which is a three-dimensional view. So again, back to squints. Why early detection and treatment is important? Because we can ensure, if we detect early and if we treat early, the binocular vision, the development of three-dimensional vision or stereopsis is enhanced, and amblyopia is taken care of, and we can detect other pathologies like cataract, retinoblastoma, things like that we have mentioned earlier. And finally, when the child starts going to school, it becomes a cosmetically unacceptable thing. So we can treat early and make the child more self-confident to go to the society. There are so many so many types of squints. Could be isotropes, which is a convergent squint. Exotropia is a divergent squint. Then there are vertical squints as well, and there are paralytic squints as well. I didn't include it in this classification. So how to manage a squint? The principles of managing a squint is first that we have to exclude any neurological pathology, and we have to do a thorough ocular examination and exclude other ophthalmic pathology as well. And we optimize the visual acuity by several means, and we optimize the three-dimensional vision or depth perception or stereopsis by treating the squint. And finally, as I said earlier, cosmetic appearance also important. So I reiterate this point. When there is a squint, we have to investigate for a cause. So the child may look like this. When we dilate and see the fundus, we can find it may look like this. So this is a tumor arising from the optic nerve, which is a retinoblastoma. And we'll move on to the next topic, refractive errors. Refractive errors are common than we think. About 15% Sri Lankan school children have refractive errors. School medical inspection does a tremendous job to detect these undetected refractive errors in children. And we have to sort out these refractive errors before the child gets permanent loss of vision. So red dye in a child, again it's an important topic that you might encounter on and off. So when to refer, you should know. So if the red dye occurs in a neonate, that is a baby less than 28 days, that warrants indication the referral to the ophthalmologist. So this indicates ophthalmia neonatorum, which is a congenital infection, and we have to look for gonococcal syphilis or HSV infections. So red dye again could be a feature of corneal ulcer. So if you see something like this, these are just pen torch approaches, not slit lamp photos. So if you see something like this, please do not give steroids. You can give a antibiotic eye drop until the patient reaches the ophthalmology opinion. So you can give us topical antibiotic like ciprofloxacin until the patient goes to an ophthalmologist, but it needs urgent referral. So child with a corneal foreign body definitely need early referral because it can get infected and can have vision threatening problems. So this sort of a corneal problem, corneal foreign body can be seen even with a pen torch. So again, please give only antibiotics. Do not give steroids or antibiotic steroid combination eye drops. Most of the allergies, or technically we call vernal keratoconjunctivitis, allergic eye disease, most of the allergies can be managed in general practice. But severe allergies like this, either subtarsal papillae or perilimbal papillae, has to be referred to an ophthalmologist to manage, because they need steroid eye drops very frequent and perhaps a long-term treatment of tacrolimus as well. So when you can manage a child with allergic conjunctivitis, mild symptoms, and you have to know itching is the key symptom of allergy. A child may have a history of atopy. These are the eye drops you can prescribe in your practice: olopatadine eye drops, epinestine eye drops, ketotifen eye drops, and you can give your favorite oral antihistamines as well. Cold compressors may help, and perhaps you can advise on avoidance of allergen. So when to refer a child with viral conjunctivitis? So viral conjunctivitis is common among preschool and school-going children. You can very small children develop preseptal cellulitis. If the child struggles so much that you can't see the cornea, please refer. If symptoms persist more than 3 days, particularly photophobia and eye pain, if it persists, please refer to an ophthalmologist. So subconjunctival hemorrhage is a very common complaint. So parents might get so much alarmed and come to you, but this doesn't need any treatment. Most of the neonates, they have this sort of mild subconjunctival hemorrhage due to birth trauma. You can't call it trauma, but birth-related subconjunctival hemorrhages are common. But toddlers, when they come with subconjunctival hemorrhage, you need to exclude accidental or non-accidental injury. And repeat subconjunctival hemorrhage needs proper investigations. Excess tearing in a child. So if the eye is white like this, it is not conjunctivitis. So typically they present during their neonatal period or infancy, before first year, with white eye, but there is a purulent-like discharge. It is not purulent, it is only mucoid discharge. And so it is due to nasolacrimal duct obstruction. So here again, no antibiotics required. So culture ABST will not help because it is not an infection, and you can advise the parents to massage the nasolacrimal duct from top to the bottom. And cleaning of the discharge can help to alleviate the symptoms. And ophthalmology referral is indicated. If you are not sure about the diagnosis, you can refer to the ophthalmologist. Or if the symptoms last more than 12 months, you can refer to the ophthalmologist. Or if there are signs of any infection, if there is red dye, if there is periorbital edema or cellulitis, things like that, you can refer. So again, excess tearing can have other differential diagnosis as well. If it is acute onset, have to suspect a corneal foreign body. It may be the initial symptom of conjunctivitis, viral conjunctivitis. If it is related to writing or reading, has to assess vision, because it could be the initial sign of refractive error. Chronic tearing with photophobia and blepharospasm may indicate childhood glaucoma as well. So trauma again is common in our clinics. Periocular trauma and ocular trauma are common. So children can suffer from trauma at school, in their playground, at home. There are various types of trauma. But most of these trauma cases need urgent ophthalmological attention. So what are the vision related problems in children? In other words, what are the refractive errors we find? Myopia is common, astigmatism is common, and amblyopia due to these errors are also common. Then squints we have already spoken about. So what is amblyopia? The definition is reduction of best corrected visual acuity. That means we have to correct the vision. We have to give glasses, or we have to, if there is any pathology, we have to treat the pathology appropriately before diagnosing amblyopia or lazy eye. So it's not a lay term, it's a proper medical term. So you have to correct the vision and see whether there is an improvement or not. So reduction of best corrected visual acuity of one or both eyes that cannot be attributed to exclusively to a structural abnormality of the eye. So it develops during childhood, early childhood, and results in interruption of normal cortical visual pathway development. So it is clinically defined as difference of the two eyes, best corrected visual acuity, 2 or more lines. So it could be unilateral or bilateral. So amblyopia is the most common cause of visual impairment in children, still common in our population, and so it persists into adulthood, and the prevalence in adults is 1 to 4%. Reduced vision due to amblyopia is about 1 to 4% depending on the population. So the amblyopia could be caused by untreated squints or untreated refractive errors, and there is a category called deprivation of stimulus due to cataract, that is media opacities, cataract or ptosis. So how we treat for amblyopia is we have to detect the cause, whether it is due to refractive error, whether it is due to ptosis. We have to diagnose the root cause properly. and we have to first treat the root cause, and then we have to monitor the development of vision in subsequent examinations. So how we treat amblyopia is, we first if it is related to refractive errors, we prescribe glasses first. If it is not improving vision, then we have to do occlusion therapy. There we occlude the better eye and allow the weaker eye to be used by the child for a prolonged period of time, hoping the cortical pathways will regenerate. And we have to monitor for the compliance of the child. Yeah. So correction of the cause is an important step in managing amblyopia. So it may involve surgery for squint, surgery for ptosis, or surgery for cataract as well. So myopia, as you know, is the short-sightedness. About 10% of school-going children are affected. So common symptoms are going close to TV, struggling to go back to the back row, and so at presentation, a lot of children may be amblyopic due to myopia. And if it is unilateral, it is very, very amblyogenic, and we have to detect and treat correctly. Astigmatism is another common cause of reduced vision in children. This is due to asymmetry of the corneal diameters. So as you know, cornea is a spherical structure. There is a vertical and horizontal curvature. If there is an imbalance between the two, we call it astigmatism. So about 5% of school children have astigmatism, and they require to wear glasses. Again, the symptoms are similar to myopia, but this is even more amblyogenic, can cause more amblyopia. Next topic is retinopathy of prematurity. So this used to be an important cause of blindness in Sri Lanka, in Sri Lankan children, but now with modern screening and detection and treatment, the blindness has become very, very rare, extremely rare. But still it can happen due to loopholes in screening and management. So we have very advanced way of treating retinopathy of prematurity, and it frequently requires multidisciplinary approach, whereas prevention of ROP is by neonatologists by regulating the oxygen, and ophthalmologists screen and detect, and pediatric ophthalmologists treat for this condition. So what causes ROP, what causes retinopathy in premature babies is the prematurity itself. Prematurity can be defined by birth weight or gestational age. So why it happens is, it is because of the development of retina. So retina starts developing at the age of 16 weeks of gestation from the optic disc. The blood vessels start sprouting out through the retina, developing retina, and the blood vessels reach the nasal side of the retina around 32 weeks of gestation. And the retina fully vascularized by the age of 38 to 40 weeks of gestation. So this chart bit complicated, but it shows the development of retinopathy of prematurity. The root cause is hyperoxia caused by giving oxygen. So this is how we do retinopathy of prematurity screening examination. The baby is held and we put a local anesthetic eye drop and put a lid speculum and examine through an indirect ophthalmoscope. So technically retinopathy of prematurity can develop in the center of the retina or periphery of the retina. The central part of the retina, if it is affected, it can cause severe visual impairment. So these cases we have to detect early and treat appropriately so the vision can be preserved in these babies. So this is classified according to the severity of the disease. There are several stages. Stage 1 is only a demarcation line between the vascularized and avascular retina. Stage 2 is little bit of exudates along the demarcation line. Stage 3 is neovascularization or retinal vascular proliferation, abnormal proliferation in the vitreous. And when it goes to stage 4, it's a subtotal retinal detachment, and stage 5 is total retinal detachment, where the blindness is inevitable. Plus disease is a specific term which we use to describe the severity of retinopathy of prematurity. So this is very important to know when to refer a baby for retinopathy of prematurity examinations. You don't have to refer all the babies, but there are several babies you must refer. So the babies born before reaching 1500 grams birth weight, or babies born before 32 weeks of gestation or less, must be referred. So if one of the above criteria is there, you have to refer. Also, you can refer any baby whom you think there is a risk of developing retinopathy of prematurity due to oxygen therapy and due to neonatal insult. So we are bound to examine that baby at least once to make sure the retina has fully vascularized. The first examination should be done between 3 to 4 weeks after the birth. There's no point of examining the baby soon after birth. We have to wait until we have to give some time for retinopathy to develop. So the next topic is retinoblastoma. Retinoblastoma is a malignant tumor of the developing retina. Particularly, this happens in very young children. Usually, the onset is before 5 years, but most tumors are present at birth. So, if the red reflex is done, if the red reflex test is done in neonates, we can detect most of the retinoblastoma cases. So this is the prototypic cancer which develops in humans through the RB1 gene, mutations of RB1 gene. Retinoblastoma can be classified according to the size and the location of the tumor. Very small tumors located away from the disc and macula are called group A. Bigger tumors located close to disc or macula called group B. When the even more bigger tumors are called group C, and when there is vitreous seeding, we call it group D, and very large tumors occupying the whole eye is called group E. And very rarely extraocular spread, which can affect the not only the vision, the life is affected in rare cases, but very extremely rarely found in Sri Lanka. But still we may find one case in 5 years' time. But in African countries, this is very common. So this is literally untreatable. So how to detect retinoblastoma early? Through the red reflex. So if the red reflex is done in newborns and children, we can detect red reflex. We can detect retinoblastoma cases. So please don't wait till until the parents come and complain. So if we can detect retinoblastomas by checking the red reflex properly. So having said that, I conclude the lecture. So pediatric ophthalmology is not an easy subject. So as you can see, these two pictures were taken literally few seconds apart, and I'm examining a baby in an incubator, and you can see the sweat coming from my neck due to very stressful examination. So these examinations are not only stressful for the patient, it is very stressful for us as well. Thank you.
Thank you very much to Dr. Hiranya Abeysekara, consultant pediatric ophthalmologist at Lady Ridgeway Hospital for Children, for his excellent lecture and the precious time. And I sincerely apologize all of you on behalf of lecturer, since he had to attend for an urgent surgery at the moment. So he will not be able to answer the questions at the moment. But we had several pre-session questions. Most of them were covered during the session. And still, if you have any questions, we ask all of you, please send them to our Shri email, and they will be, we will contact the lecturer, and we will supply the answers for you. Now we will send the link for e-certificate. You can fill that application and please give a kind feedback about the today's CPD. Thank you.